I now request Sir to deliver his address.
Thank you very much, Principal Joshi. It's a great honor and a privilege to be here this evening. I know it's Valentine's Day and you should be, I know this is a very English British custom, but I've already received my roses, so I'm quite happy. It's a great privilege and an honor to be here to be delivering Dr. G.V. Pandit Memorial Lecture and listening to the list of names of people who've preceded me. I'm even more humbled by this invitation. So I'd like to thank Sumitra for extending the invitation and Professor Joshi for hosting the evening. I aim to speak for about 40 minutes and set some questions and challenges, and I hope very much that we can have a discussion afterwards. And if you have any questions, what we were thinking about, we were hoping to publish some of the material from the lecture, and if you wouldn't mind writing the questions and passing them on to Sumitra so that we can incorporate those in the final discussion document as and when it develops. World Psychiatric Association is the sort of world's largest psychiatric association, representing 200,000 psychiatrists around the globe. It has over 139 organizations as its members from 117 countries, and more applications are coming on a daily basis. So it does many things, and one of the challenges for any president, and I took over the presidency in September last year, that we have to produce an action plan. So what is it that we're going to be achieving during our term of office? And my action plan was basically 5 streams. The first stream was about domestic gender-based interpersonal violence. Second stream was child sexual, physical, emotional abuse. Third is about prisoner mental health care. Fourth is of underserved populations and groups such as asylum seekers, refugees, migrants, elderly, people with learning disability, lesbian, gay, bisexual, transgender individuals, etc. And the fifth stream is about mental health promotion. But as you would sort of see the streams, they're both vertical and horizontal. So if a woman is being beaten up and the husband ends up in prison and the child is being neglected, what impact it has on people's mental health. Now you may quite rightly say, well, what's that got to do with psychiatry? And I'll submit to you that it is everything to do with psychiatry. All psychiatry is social. Firstly, we know that attachment patterns that children have towards their parents in childhood change the brain structures in ways that we are only now beginning to understand. It is about psychiatry because we as doctors have a major public role in being public advocates for our patients and for the population general health. So these 5 themes formed my agenda for public mental health. And as I started working about it, looking at it, it became very clear that this goes beyond public mental health. It's about social justice. And I'll do sort of several things in this talk. I'll try and define social justice, and I will also argue that quite often the term social justice is very badly misunderstood. It's one of those terms which can mean anything you want it to mean. I would also touch upon issues related to parity of esteem between physical health and mental health. I will talk about human rights and of course the impact it has on delivery of health services, whether they are physical or mental. Now, one of the things that really intrigues me as I travel around the world looking at services, and different cultures have different ways of looking at distress. Cultures have very different way of expressing distress, and how do we then try and make sense? Can we have a universal charter of human rights? And my argument in short is yes, we can. But social justice is something much broader, in the sense that one of the advantages of using a term like social justice is that it gives us cultural relativism. So in different societies we can employ different aspects to deliver what we want. And this is my personal tribute to Dr. Pandit, and I am not going to go at any length because Professor Joshi has already talked about it. I want to start off with some definitions. One of the major issues in psychiatry is that we kind of understand what mental illness is, but we don't really know what mental health is. And the struggle to try and figure out, are there two different things? Can you be mentally ill and mentally healthy, or does it have to be one or the other? And if it is one or the other, is it part of one spectrum, where you start off with mental health on one end of the spectrum and end up with mental illness on the other? By and large, we know what we mean by mental health, and it's like those kind of terms like parity of esteem, like social justice, it can mean anything. But I would suggest is that it is about successful performance of mental function, by and large, which can lead to fulfilling relationships and productivity. It can allow us to adapt to change and deal with change in a way which makes us better, which makes us function better. Difficulty with such a term also is my mental function the same as anybody else's in this room? And if there are variations, can they be compared? And if so, what does that mean? And challenge, particularly as a clinician, then is at what point does mental health stop and mental distress, mental disorder, mental illness begin? The fact that I am using three terms also means that psychiatry is not clear as to what we mean. We confuse between mental distress and mental disorder and mental illness. One of the biggest tragedies in England, certainly in the last 15 years, has been, and that's my personal gripe, you can choose to ignore it, which is that we've stopped using the term mental illness. We use terms like mental health issues. Now, at one level, yes, it's kind of probably less stigmatizing, but at another, what does mental health issues mean? And I was at a meeting when somebody was presenting a case, and she stood up and said, Mr. Smith is suffering from mental health. I said, surely that's a good thing. And why should it be seen as suffering from mental health? But I think that's a debate that as a society we need to have. And part of the argument about social justice is that we haven't got it clear what psychiatry's contract with society is. I kind of vaguely know what you would expect from me as a clinician, as a psychiatrist. But apart from the fact that I want you to pay me large sums of money to do my job, I'm not sure what you want from me. Is it that you simply want me to do risk assessment and tell you that Mr. Smith is at risk of harming himself or others and therefore should be locked up or forcibly treated, or family be excluded from social housing or whatever? So part of the challenge in this whole social justice debate is about this contract. and we know mental health is indispensable to our functioning. And equally importantly, I think I would also suggest that increasingly the focus in psychiatry is on recovery, which means that in spite of the symptoms of psychiatric disorders, patients can continue to hold down jobs, can work, can have relationships, things that you and I would normally expect to do. Now, in terms of successful functioning, again, we don't know as a group, and perhaps we can have some discussion later on. As a group, do we agree what we mean by successful functioning? How do we measure success? And that's one of my early challenges to you in a country which is going through a rapid cultural change and culture in transition. How are those norms going to be measured? How are they going to be defined? How do you decide functioning? Having a 22-story house in the center of Bombay a symbol of success? Having 3 meals a day without having to beg, borrow or steal is a symbol of success. And again, within that, what does it tell us about the internal workings of the mind? And it is, wellness is about covert expression of values, and values differ across cultures, we know that. And to assume that a country with 1.2 billion people, 22 languages, and I can't even remember how many states we have anymore, is there such a thing as homogeneous culture? And how do we then identify what is normal, what is abnormal, what idioms of distress people are using to convey to the clinicians and to others that I am suffering? And again, part of the debate is about outcome, then how do we measure those outcomes? So by and large, mental illness is about a diagnosable order. Now you and I can again have a long debate, what do we mean by diagnosable and by whose criteria? If the diagnostic systems have been developed in the West, can we blindly apply them to other cultures and other countries? Again, the typical psychiatric answer would be yes and no. Maybe in some conditions we can and some we can't. Now, that's a debate with the whole of medicine. Perhaps in medicine and surgery is far easier that when you have appendicitis, you know where the pain is, you know what the blood test is going to show, you know what the treatment is going to be. Whereas if I am sitting with a patient who has, I think, mental illness or mental disorder or mental distress, I have no way of knowing what's going on in the internal world except what the patient chooses to tell me. There are very few objective tests. So part of the challenge for us as a society is how do we define those and how do we define functioning. 2 examples in the range of psychiatric disorders. Alzheimer's is becoming the next big thing. As people are living longer, you're going to see more and more people with Alzheimer's. Quite clearly exemplified by alterations in thinking, loss of short-term memory, long-term memory is fine, whereas depression exemplifies a mental disorder, but largely marked by alterations in mood. ADHD, which has become incredibly fashionable. The number of American children who have ADHD and are on medication for it is massive. 20 years ago, nobody was talking about ADHD, and it is again a mental disorder, but identified by behavioral disturbances. So what I am trying to sort of illustrate here is that there is a range of problems and there is a range of expressions of distress. And my favorite example, in a few years ago I did a piece of work where I compared symptoms of depression between patients presenting in a clinic in Bombay and in Haryana, in my hometown. And you would think that they would be roughly the same, wouldn't they? But they were not. Very marked differences in the terms people were using, very marked differences in the symptoms, and comparing those symptoms with depression in the West, you are getting a very different range of symptoms again. In the West, quite often you see notions of guilt. People who feel depressed, they feel guilty, and guilt is a very Judeo-Christian concept. Whereas in India you tend to see a lot of shame, that I have brought shame upon myself or the family. So there is specific differences in terms of culture and how symptoms present. But equally importantly, social determinants play a major role. And social determinants basically mean that if you are poor, you are more likely to be depressed. Overcrowding, poor housing, lack of education, number of factors have been shown that there is a gradient effect, that if poverty keeps going up, symptoms of psychiatric disorders keep going up too. Now, question for the society as a whole is, can we stand by and say, well, it's okay to have those differentials between the very rich and the very poor, and if not, what do we, if anything, ought to be doing? We understand that. How do we conceptualize it? Poverty in India, is it the same as poverty in the UK or poverty in America? Perhaps not. And again, we were discussing earlier today that in inner city Boston or in inner city London, quite often there is 4, 5 generations of unemployment, heavy drinking, promiscuous sexual behavior, lots of problems, and people see no hope. Whereas poverty in India, at least people have a sense of hope. Now, I may be idealizing it, and perhaps you can tell me I am wrong, but it is what we need to be looking at. And if we are going to deliver any kind of social justice, we have to start by looking at what are the social determinants of psychiatric disorders. And these have to be looked across non-health sectors. Mental health is far too important to be left to experts. It is everyone's business. Part of the tragedy, certainly in the West, has been René Descartes and his philosophy of mind-body dualism, that somehow mind and body don't talk to each other. And part of the reason for the dualism, I learnt yesterday, was the role the church played. When René Descartes was writing his theory, the church saw mind as their property, whereas body was the individual's. So it made sense to have mind-body dualism, but that makes life very, very difficult in clinical settings. So somehow, if you have diabetes, you can't be depressed, or if you have cancer, you can't be depressed. Patently not true. And one of the advantages of the Ayurvedic system is that it looks at things like environment in which you live, weather, diet, relationships with others. So it's a much broader holistic picture which Western psychiatry tends to ignore. So what we need to be looking at is the health inequalities and health status. In that, we know the fair gains from economic prosperity are incredibly important. In 2013, 2 one epidemiologist and a physician wrote a book called The Body Economic. If you haven't read it, I'd strongly recommend it. What they did was they looked at the data from economic downturns since the Great Depression and looked at people's health, physical and mental. And they showed quite conclusively that if the governments opt for austerity, people's physical and mental health worsens. But if they invest at the time of economic downturn, people's mental and physical health improves. Now make what you will of it, there is evidence, but would politicians listen to that kind of evidence and say we are going to formulate policies based on evidence? Of course they would not. That is not their job. Their job is to be, no, I won't say it, but it is that in the whole system of health inequalities, part of the role for all of us is about health advocacy. And for the first time in about 15 years in England, rates of suicide have started going up since the economic downturn. Very clear evidence that in the last 5 years rates have shot up. Just when you need more input in the times of economic downturn, certainly in the West, resources are being cut. In India you have a specific problem, which is that India spends less than 1% of its GDP on health, of which a even smaller proportion on mental health. America spends 21% of its GDP, most of Europe between 8 and 12%. So again, what that tells us is about cultural differences and cultural expectations in delivery of healthcare and developing healthcare systems. In the last 3 years in the UK, parity of esteem between physical health and mental health has become the buzzword. You talk to any politician and they are talking about it. When you ask them to define it, they can't. It is one of those words which has come from civil liberties. I give you equal respect. Who would disagree with that? Would I do anything about it? Of course not. That does not mean anything. So again, I am going to raise some questions for you that in the Indian context, what are the challenges to this parity of so called parity of esteem? First and foremost is about stigma. Stigma about people with mental illness, stigma about people who look after individuals who have mental illness, against psychiatry, any number of things, and it is related to external discrimination and prejudice. Now again, stigma is one of those words which can mean anything, but in legal terms discrimination is much more helpful, because you can enact laws to get rid of discrimination, because that is equality in law, and therefore something has to be done. I have talked about Cartesian dichotomy, but there is a conceptual failure in many paths to understand the causal pathways of mental disorder. What causes it? Some things are fairly straightforward, drug abuse can lead to psychosis, but why would you start with drug abuse in the first place? What is it? Is it simply experimenting? Is it part of growing up? Is it something else? Is it genetic? Is it social? Is it psychological? Is it behavioral? So we need to be looking at those methods, and partly this mind body dualism means that there is a clearly delivery chain failure, that if you are mentally ill and you have cancer, cancer specialists are not going to look at you that kindly. If you have cancer and become depressed, oncologist is not going to be able to identify that you are depressed. They will see that this is a normal reaction to being diagnosed as having cancer. So what does that mean? And certainly, I mean, one of the major strengths of MBBS courses in India is emphasis on preventive medicine. We are taught a lot, but not a word about mental health in that context, in the public mental health context, and what does it mean. And perhaps one of the things that I am delighted that Dr. Vatve is here, that Indian Psychiatric Society can use preventive and social medicine as a way in to deliver public mental health agenda. So what is social justice? When in doubt, always start with a definition. What do we understand by it? And one of the major challenges is that it's kind of seen as a virtue that we should all aspire to, that everybody is equal. But these virtues create institutions. Now if we look at, again there's a sort of very interesting book by Goff called The Social Contract. He describes the social contract initially as there was a contract between the king and the subjects. Subjects obeyed the king in return for protection. So they assumed that the king would protect them and they will do what the king tells them. That social contract then led on to more professional contracts which are not explicit, which are implicit. You have a certain expectation from any doctor that you want to go and see, that he or she would be professional, he or she would be trained, would be an expert in what they know, what they communicate to you, and there will be certain roles and responsibilities that he or she would carry. How do you make sure that that happens? And particularly in the context of medicine in India, sometimes I despair. With so many new private medical colleges opening, the quality control is missing at times. We need to know that as a society, how do we deal with that? Are we okay with it? And if we are, fine, let things carry on. But if we are not, what are we going to do about it? Is that part of this virtue that we create an institution which gives us those standards, standards of learning, standards of assessment, and standards of clinical practice? And it is, institutions by and large were created to provide good for the individual, so the individual gets looked after. But it is also a responsibility upon all of us to work with others to create and design and improve institutions. And it has been argued that social justice and economic justice go hand in hand. Again, we can debate about that, whether that's true or not, and I've touched upon social determinants, and it's very clear that they play a role, and therefore we need to be aware as to what that means. And the principles of economic justice are about distributive justice, participative justice, and social justice. Distributive justice is about profits and wages. Participative justice is input from labor and capital, and social justice is feedback principles. So in the Indian context, how does this fit in? When Kelso and Adler wrote the theory, it was very much a sort of capitalist principle, which was about labor producing certain things which get sold, profit which gets shared with labor or not, but the kind of circle continues. So at what point in a culture like India in transition, where you see such massive disparities, where does this distributive or participative justice fit in? And this statement, the first time it was the term social justice was used was in 1840, which is that society should treat all equally well who have deserved equally well of it. The emphasis has been added. This is the highest abstract standard of social and distributive justice towards which all institutions should aspire to. My challenge again is it the institutional problem, or is it the institutional imperative, or is it the individual one? And if so, how much power as an individual I have to change any institution? Are institutions made of buildings or of people? And how do people influence what the institutions are doing in their names? For me, social justice for mentally ill is very, very simple. It is about equality of outcomes. It is equality in recovery. It's about having same kind of access to housing, social connections, employment, money, standards of living. How do we go about that? Can we balance the economic and social justice in any way, or are they sort of so far apart, or economic justice is far more important than social justice that we dare not even look at it? One of the major issues in looking at social justice is to look at it in the capabilities framework, and it's a key capability. Do I have the capability to be healthy? And that is about looking at my ability to keep myself healthy, and if I become ill, to get better. And it is quite often partly the social inequalities that are touched upon, but social arrangements, and particularly in a huge country like India, there are other social arrangements which thwart or neglect individuals' capability to be healthy of hundreds of millions of people, and that does not get recognized as unjust. It's just taken as a somehow part of the issue is where does the individual responsibility finish and the social responsibility start. And quite often, certainly in the West, no matter what the problem is, it's seen as the individual's responsibility. If you smoke and you get cancer, you get no sympathy. If you eat McDonald's and put on weight, you get no sympathy. That somehow you brought it upon yourself. The fact that there might be genetic factors contributing to it does not even get noted down. So capability to be healthy is looking at the causes, constraints, distribution patterns of goods, of things that we need, food, ability to be healthy, and that's part of the social justice argument that I want to put forward to you. People's health or clinical outcomes are socially produced. Society tells me how to define illness. Till about 1974, in the Diagnostic and Statistical Manual of American Psychiatric Association, homosexuality was a medical illness. 1973 or 74 it was removed. So overnight millions of people were cured. They did not have an illness anymore. Society tells me what sickness is, and in the UK, when I first landed there 34 years ago, if you were off sick over 24 hours, you had to have a note from your GP. And nowadays you are allowed to have 3 days off without a note from the GP. So what changed? Somewhere along the line somebody decided, nah, it's too much bother to push the GPs to write sick notes. so let us change the rules. So, again the definitions of what is sickness, what is deviant, changes from society to society. We as doctors are taught to diagnose and deal with diseases which are dis-ease. What is the pathology? Patients are interested in illnesses, which is that how does this disease affect my social functioning, my ability to live, my ability to earn, my ability to have successful relationships. And that is part of the debate between medical profession and society, which has not even started yet, that we need to look at what is it we are treating. Are we treating the individual, are we treating the symptoms, are we treating the society? Perhaps all of the above, but the point really is that society tells us what is deviant, what is sickness. It tells us where to seek help, and if you do not have enough resources, you will go to the nearest resource possible, which 9 times out of 10 are your family members and others who have been through the same experience. A few years ago there were studies from America which suggested that between 70 and 90% of all illness episodes are treated in personal, folk or social sector. Only between 10 and 30% reach professional sector. Physical or mental, does not really matter. So, part of the argument about sort of social justice and access to the system is, how do we define that patient's journey? Where does it start and where does it end? And where do we start to intervene? And obviously there are political, economic, legal constraints both nationally and internationally. And we know the social environments produce, we are products of our social environments. The way we are brought up, the way we are brought up also teaches us the way we think, and cultural patterns of thinking across different cultures and societies are very, very different. We know that. So, what does it mean in terms of capability? It is about partly biology, it is about behavior, it is about external physical environments, and it is about social conditions. And I would suggest that all 4 of those can be affected by a number of external factors that we need to be thinking about and looking at where to intervene and how to intervene. And it is again the pathway into care that patients follow, no matter what their physical or psychiatric symptoms are. At each step society can intervene or facilitate one way or the other. When we look at the patient, we look at the individual who is sitting in front of us, but we forget that the patient is surrounded by his or her family, who are the caregivers, who have to deal with. The patient comes to see me, and if they are lucky, I see them once a month for half an hour, and rest of the 29 days and 11 and a half hours, I have no idea how they are functioning, but it's the family who are dealing with it. So, part of the challenge for society in terms of delivering any kind of social justice is looking at those proximal factors, and those proximal factors then get impacted upon by distal factors, which is about the larger society, larger cultural values and social conditions. I like this quote from Susan Sontag, which is that humans are born into the kingdom of the well and the kingdom of the sick, passport of the former, and everyone will have to reveal themselves as citizens of the latter. So, if a person wants to be healthy, if I want to be healthy, then the system has to facilitate for me to be healthy. And that's about capability. It's personal responsibility that, if I know that I have family history of diabetes, I need to be careful as to what I eat, control my weight, do some exercise. It's in my control. But just because I won't do it, I shouldn't be punished for it, or should I? And again, that's something that the society needs to be thinking about. And obviously, society allows me to be healthy by any number of ways, or allows me to be unhealthy. And it is cultural responsibility again about definition and deviance, and looking at how we interact between society and culture and the individual, and the interrelationship between the three. Boers talked about diseases as an internal state, and his kind of definition was that health is absence of disease, and that is a problem. That you can have a disease, but you can be healthy. You can still function, depending upon your definition of health, you can function normally no matter what the problem is. And what it does to us is create this again capability of living a life free of problems, in whichever way you define problems. And it is about bodily integrity, it's about using our senses and imagination, it's about dealing with our concepts of goodness and concerns for other species, etc. And you can argue that these are all very kind of idealistic ways, and it's not possible. Yes, and it is part of the problem is that we see private health or individual health completely out of context with public health. And it's the public health which is about social justice. It is about having equal access to information. And if I know that if I continue smoking 20 cigarettes a day, my chances of developing lung cancer is 1 in, and if I am making that decision, then as an adult I should take the responsibility. But if I then fall ill and I have to undergo surgery, part of my lung has to be removed, or I have chemotherapy, who pays for it? What does it mean? And is it simply about the productivity of the individual, or is it about productivity of the society, and how do we measure that? One way of looking at this, and I think that's quite an exciting way, is rather than looking at factor A causing condition B, we should be looking at a web of causation. There are multiple factors which cause disorders, particularly psychiatric disorders, and again I've touched upon biological, psychological and social factors, and sometimes you get more biological vulnerability, sometimes you get more psychological factors, and what does that mean? But it allows us to determine those factors which affect both presentation of the disease and interventions as well as prevention. And that again is about health equity. What does it mean? And that's just because I am ill, does it make me an inferior individual? How does it affect my rights, access to care, access to reasonable standards of living, access to other things in life that other members of the community who are not ill may have? And again we can sort of discuss that. Health equity is about protection of human rights, and they are fundamentally linked. One of the major problems in medicine has been that single etiological model causes that A causes condition B, relates to very much the kind of human rights model. How do we fit that in? And when we talk about my capability to be healthy or my right to health, which rights based parity am I talking about? Is it simply health based? Is it about gender? Is it about age discrimination? Are we looking at human rights, civil rights, minority rights and children's rights? And again, as a society we need to be looking at what does that mean. And properly constructed health rights can offer justification for adequate resources to health care, and that is probably one of the key messages. We need to understand that, so that in the web of causation, in the complementary framework, how do we put together epidemiological and demographic analysis of the social determinants, various levels, linking them with prevention. Health rights also allow us to the potential to clarify and redefine the fundamental purpose and duties of the individual as well as that of the state. We just assume the government will do A, B and C, and in England at least this whole notion of nanny state, that state will stop you from misbehaving. Labour Party always says the government is for the good of the people. Tories always say government should take its hands off, people can do whatever they want. I don't know which of those is better. I have a personal view, but as a society how do we fit that in? And the tragedy really is that quite often, like with human rights, health rights are used as an opportunistic term, but nobody knows what it means and where does the responsibility lie, and nobody would look at the conceptual gaps between the ideas of right, ideas of health and ideas of social justice. How do we try and map these? So do we look at a different way of conceptualizing access to rights? If so, is simply human rights based parity acceptable? Patients with mental illness are 10 to 15 years more, they are likely to die 10 to 15 years younger than those who do not have a mental disorder. It has been argued that part of the problem is the illness itself and people commit suicide, etc. Part of it is that medication causes so many side effects that it leads to obesity and diabetes and so on and so forth. But is it fair that just because you have a psychiatric condition somehow it's acceptable for the society to say yes, you can die 10 to 15 years earlier compared to those who don't have it? So how do we deal with that? Is it should we be having disease specific responses in terms of health rights, capability to be healthy, human rights? Should one size fit all? And it will be very interesting to sort of have legal views on that. Quite often I am told when I have given similar talks in India that this is against our culture, the whole idea of human rights. Is it? West can't come and tell us what to do. No, I am not saying that. I am just raising certain issues, but we need to, as a enlightened society, as a civil society, we need to know what is going on. And I am not going to go through the WHO quality rights kit, and if those of you are interested in looking at it, it is on the WHO website, and it gives us some framework in looking at what are the rights for patients to have adequate standards of living, social protection, highest obtainable standards of physical and mental health, right to exercise legal capacity and to liberty and security, and you can then use this framework to assess how services are being delivered. Now again, there is a big challenge in India where majority of the services both in psychiatry and in general medicine and other medical specialties are being provided in the private sector. How do we measure this, and who does, and who controls it, and who regulates it? And those debates need to start fairly soon. I think I am going to sort of skip through some of these, but I want to leave you with further. Why should not patients with mental illness be full citizens of any society? Until about 1980 something, patients in psychiatric hospitals in the UK were not allowed to vote. If you have had a psychiatric disorder and have been admitted compulsorily, you cannot enter America, your visa will be denied. Is it fair? If you tell me it is fair, I need to know why you think it is fair, and if it is unfair, then why aren't we doing something about it? Why are not we talking to Barack Obama and say you got to change that? We know that social inequalities affect health, both physical and mental, but more for mental health. There is some fascinating work done by an epidemiologist, Sir Michael Marmot in London. If you have ever seen the London tube map, which tells you where you go and which tube line you take, if you look at the central line, which is the red line, from Liverpool Street station, for every station that you go east, and if you are living in those areas, your longevity drops by a year per tube station. Now, one would think this is such a small country in, rich 5th largest economy in the world, and why should such disparities exist? We need to start challenging those, that why is it those social inequalities affect mentally ill individuals? Why should outcomes be different for people with mental illness? And you can equally say, some of the reasons is that we don't understand mental illness. Then we need to put more money in research to be able to give those answers. And we need to be very clear about the interactions between physical and mental health. So when we look at parity of esteem or social justice, would human rights based parity have better success? Would it bring better funding for research and services? Would it bring better care? I am just raising those questions, I do not have answers. I know for sure that billions of dollars have been spent on brain research, and we are nowhere near understanding the structures of the brain and how it functions, much less the mind. So should we pour more good money after that? I do not know. Who defines better care? Is family always the best carer for an individual? The fact that I am using the word always means it can't be the case. So what do we do about that? But we do need an urgent debate at national, regional and international level about both human rights based parity and social justice. Is it socially just that what we do to patients with mental illness is acceptable in today's civil society? So once again, thank you very much for being here, thank you for listening, and thank you very much for inviting me.